Hello, everyone, and welcome to a recording that we're making for you here tonight from the Children's Tumor Foundation. My name is Kate. You might know me from the Ask Kate videos on CTF's YouTube space, and I'm really excited tonight to be talking with several really fantastic people. You may have heard that there was recently some changes made in diagnostic criteria for NF1, and we wanted to just make a video that would be accessible to anyone who's interested in understanding a little bit about what that means and what it might mean for those who are living with NF1. So I'm really excited to be here tonight with Dr. Viskochil, Dr. Yohay, and Alwyn Diaz, and I'm just going to let them introduce themselves.
Sure. My name is Alwyn Dias. I'm 45 years old and I have NF1. I've been connected to CTF for about 6 years so far, and they've been an amazing support system that I wish I had gotten in touch with earlier in my life.
My name is Kaleb Yohay. I am a pediatric neurologist and I run the Comprehensive Neurofibromatosis Center at NYU in New York City. And I've been taking care of patients with NF for about 20 years. This coming year will be the 20th anniversary of running an NF clinic. And I've been involved with CTF that entire time. Currently, I'm on the Clinical Care Advisory Board, where we talk about lots of different clinical issues as they pertain to NF.
I'm David Viskochil, and I'm from the University of Utah. I'm a medical geneticist there. I've been there for about 35 years or so. And way back when I came out of pediatric training, I applied for a Young Investigator Award and got to work with two super mentors. Ray White was my basic science mentor, and John Carey was my clinical mentor. And so I worked within that lab to better define the NF1 locus. And back then we relied on the diagnostic criteria to determine who was affected, who wasn't affected, so that the gene could be identified. And now that the gene's identified, we are ready to move forward.
Wonderful. Thank you, everyone. I'm going to go ahead and put up our slideshow and we'll get started. Okay. There we go.
Oh yeah, there are the animations. So
oh no.
Yeah, so maybe just advance through and then
we'll fix it later.
Yeah.
Okay. Does that look like all of it? There we go.
No. More, a couple more. There you go.
There we go.
Oh.
Is that it? Okay.
Yep, that's it.
All right. Sorry about that.
All good. You said no mistakes.
Yeah, right. And it's me. I made a mistake. So what are we going to do? All right, go ahead.
All right. Well, as Dave mentioned, for all this time that we've been taking care of people with NF1, we've really had to rely on clinical features of the condition in order to make the diagnosis. And for a lot of different conditions, healthcare providers rely on different descriptions and different criteria to make the diagnosis of a particular genetic or other medical condition, which is the case with NF as well. And there are different criteria for NF1, NF2, and schwannomatosis. The criteria that previously have really been the predominant criteria that everyone has used were sort of formalized in 1986, before the gene was identified. And as many of you probably know, it's basically you have to have two of the main features that we see in neurofibromatosis. So someone can possibly have NF with only one feature, but you can't confirm that they have NF until they have two features. The features that we rely on, probably the most common one is cafe au lait spots. So having 6 or more cafe au lait spots, which are the brown flat birthmarks that we see in essentially everybody with NF1. Characteristic axillary or inguinal freckling, so freckling in the armpit or the groin area most commonly, which is also very distinctive and very particular to NF. 2 or more neurofibromas of any type, or 1 plexiform neurofibroma. So if someone has 2 cutaneous neurofibromas, which you can see in the top right picture, or 1 plexiform neurofibroma, which you can see 1 row down on the left, which are the more complicated, often larger neurofibromas that can either be superficial or internal, that can count as a criteria. In that middle panel there, you see what are called Lish nodules, which are very distinctive little raised bumps that can develop on the irises of most people that have NF1. They usually don't show up until people are late childhood, early teenage years, so may not be helpful early on. And they don't really have any clinical significance. They don't do anything to impair vision or cause any other symptoms. They're just there to help us make the diagnosis, essentially. And on the right middle line, you see there an optic pathway glioma, which is a very particular type of tumor that develops on the optic nerve behind the eye, or anywhere between the eye and the brain in the optic pathways, which we see in people with NF. We can also see in people that don't have NF, which is why that by itself wouldn't be enough to make the diagnosis. And then we'll talk more about the distinctive osseous lesions, which means there are several distinctive bone deformities or changes that we can see in people with NF, and we've relied on those to help make the diagnosis as well. In particular, a particular type of shape to one of the bones of the skull called the sphenoid wing, a bow or a fracture in the tibial bone of the leg, and dystrophic scoliosis, which is a specific type of curvature of the spine. And then finally, as depicted in the bottom right, the last feature would be a family history, somebody that you're closely related to, a parent, a child, a brother or sister that has neurofibromatosis type 1 and meets the clinical criteria that we just described. And so any two of those features, any combination of any two of those features would be enough to definitively diagnose somebody with neurofibromatosis type 1, at least at the time of the publish, that these criteria were published. And that has changed a bit. All right, we can move on to the next slide. And just as a way of introduction, I'll turn over to Dave for this slide, but one of the main things that changed in the past few years is our ability also to do genetic testing. And I didn't mention genetic testing in that prior slide because that was not part of the criteria. So Dave, I'll turn that over to you.
Okay, great. So I just wanted to bring up that even though genetic testing was not part of the diagnostic criteria, we did not ignore that. So those of us who were trying to establish a diagnosis, once the sensitivity of testing improved through the 1990s, and we could rely on a 95% sensitivity, then of course we would not ignore someone having a genetic change, which we would call, now we call a pathogenic variant or a likely pathogenic variant. And so you can see early testing for NF1 mutations grew out of once the gene was identified. It's a fairly long gene, large gene, 61 exons, spanning about 280 kilobases of genomic DNA. So there's been a recent shift to next-gen sequencing, which really improved the capability of many labs now to do genetic testing. And so the time that it becomes very important is in younger individuals who are sporadic cases, so neither parent being affected. And it may take years before a second manifestation were to arise to the cafe-au-lait spots, which usually come up in that first year of life. And they usually emerge after birth, so they're not generally viewed as birthmarks. They're cafe-au-lait macules that tend to arise in the first 1 or 2 years. So that's a perfect time that families really want to establish a diagnosis, and we can do so now with molecular testing. And that was one of the main reasons to revise the diagnostic criteria. There are a few more reasons that are shown on the next couple of slides. If we can move to the clarifications that came out of this is that...
Sorry, what is going on? Sorry guys, we'll fix it. There we go.
The clarifications include the finding of relying on bilateral or both sides, freckling in both sides, either in the axilla or groin areas, that really are one of the key manifestations that allow you to separate multiple cafe-au-lait spots from other genetic conditions that also present with multiple cafe-au-lait spots. And so if you just have freckling in one side and you're an adult, then we need to think about mosaicism. And so having bilateral freckling instead of just freckling in one place in the body allows you to be more certain about the diagnosis of NF1. There are also significant changes in the osseous lesions, such as sphenoid wing dysplasia, which is associated with plexiform neurofibromas of the face around the temporal orbital region. Over 50% of individuals will have both sphenoid wing dysplasia plus a plexiform neurofibroma. So that has stayed in because it's so specific. But the bowing of the tibia, we'd recognize after looking at many x-rays that there's not thinning of the cortex of a long bone, but actually thickening. And then the pseudarthrosis of a long bone is also still within the diagnostic criteria. We did pull out dystrophic scoliosis. That's no longer a part of the criteria, although we still use that we follow that as a manifestation, but due to lack of specificity, it does make it a little more difficult to use that as a diagnostic criteria. And then finally, we kept in a parent who has NF1 by above criteria. So no longer is it a first degree relative like a sibling. It needs to be a parent of an individual who has the cafe-au-lait spot or spots or other manifestations. And in the next slide, this just shows you the clarification. So I wanted to point out that in those who have tibial bowing, the actual bone near the curvature is fairly thick. It's not thinned, and that needed to be clarified. We think of pseudarthrosis or false joint as really a non-union of a fracture that occurs in a long bone, and primarily it's in the tibia. Next slide. And finally, this is a new addition. So in addition to the 2 or more iris leash nodules that have always been part of the diagnostic criteria, choroidal abnormalities have been identified, and this is depicted in the figure there. And ophthalmologists can detect these, and if there's 2 or more of those, then one can make a diagnosis much earlier because these are found even within the first year of life. And the next slide. We're back to the revised NF diagnostic criteria, and I pass that on to Dr. Yohay.
Yes, so basically, just to sum up this slide, the red text are the areas where there are changes. And so just to reiterate, we now require that there be freckles on both sides, both armpits or both sides of the groin, leash nodules or choroidal abnormalities, these new findings that have been described that are seen almost exclusively in people with NF and much earlier than the leash nodules, the clarifications for the bone. And then as we sort of alluded to early on, genetic testing has been used, but it never was part of the diagnostic criteria. So now, if you have a mutation or a pathogenic variant identified in the NF1 gene, that plus any one clinical criteria is enough to make the diagnosis. And one of the reasons we wanted to include that, frankly, was because it was often difficult to get insurance to cover genetic testing because we had these clinical criteria, and the insurance companies would say, well, you don't need genetic testing because you have the clinical criteria, and genetic testing isn't part of the diagnosis of NF1. And so by including it in these new revised criteria, we suspect that it'll become easier to get insurance companies to recognize the importance of doing genetic testing and the value of it in making a diagnosis. And then finally, yes, a parent as opposed to just a first degree relative. So a little bit more specific to avoid some sort of unusual circumstances that can happen with a condition called mosaicism, et cetera, that might make it a little bit more confusing. So So these are the criteria that were recently published. They were published this summer and were actually the result of a very long process of consensus among experts worldwide. It was actually a really cool process to be part of. And we hope that these new diagnostic criteria will go a long way in sort of clarifying some areas that have needed clarifying for a long time, and will help limit the number of mistaken diagnoses and also improve the timing it takes to get the diagnosis nailed down. So the earlier the better, so that children can be followed appropriately.
Great, thank you both so much. And so, as I had mentioned at the beginning, Alwyn Diaz is here with us tonight as well. As he said, he lives with NF1, and he's a really phenomenal part of our NF community at CTF. And so he's graciously agreed to be here tonight to just pose some questions that that maybe he has, as well as questions that I'm sure that in the community are going to be coming up. So I'm going to go ahead and hand this over and let Alwyn ask some of those questions to our doctors.
Thank you, Kate. It's actually an honor just to be able to be a part of this and share this information with the community. Well, as I was hearing the presentation, you know, it definitely resonated with me as an NF1 patient. One of the things that came to mind is, and I'm grateful for it, is why was the criteria needed to be revised?
I think, you know, I think for a couple of reasons. I mean, the genetic testing was probably one of the main ones, so getting that included. And then, you know, in medicine and science, we're always talking about improving specificity and sensitivity. So for any test, one of the measures of its quality is how sensitive it is. How early can it pick something up? And we, at the same time, want to balance that with specificity. We don't want to pick things up really early if we then make mistakes by picking things up that actually aren't what we think it will be. Does that make sense?
No, it does. It does. So my family's gone, I just had my son, 7 months old, and we went through IVF to do so, and I had to go through genetic testing. How else would it help patients in regards to the diagnostic criteria being revised? How else does it help patients realize their current situation?
We presume that in the future, I'm not sure how near of a future it may be, but depending on what genetic change you have, may lead to specific clinical trials that you could potentially have an impact then in those cells that are expressing the NF1 gene product, neurofibromin. If it's if not enough is made, if you knew that it was a nonsense mutation, then you could induce perhaps the normal allele that's within the cells. On the other hand, if it's a missense change, then you might be able to trick the cell into still making neurofibromin with a minimal change in the protein. So there are things in the future that we potentially will be able to change. And of course, people have thought about CRISPR and gene therapy and genomic editing that may also be in the future. It's not right around the corner, but it's something that we think about. And having that molecular testing is helpful.
So that, knowing all of that and having that be in place allows me to be very grateful. One of the things that I was thinking about as you were going through the criteria also was I didn't hear the mention of pain as part of the criteria. Now, an individual can have tumors within their body at a young age and have the capital A spots, but the tumors might not be visible, but there might be a pain that is connected to the condition. How does pain fit into the criteria?
There's actually a lot of things that people with NF1 have that aren't included in the criteria, in part because they're just not specific enough. You know, there's so many conditions that pain is a part of that it wouldn't really be, terribly helpful in making that initial diagnosis. What we do use pain for when we're, seeing a patient with NF1, we want to know first, if someone's having pain that we need to treat, and that's really important, but it also can help us differentiate between benign neurofibromas and one that might be either in the process of transforming or becoming malignant. And so it's very important in sort of stratifying or determining which patients we do additional testing on once we know they have NF1 to decide whether or not we need to work them up for other aspects of NF, like a malignant peripheral nerve sheath tumor. So,
Got it.
So that's really where we use pain from a diagnostic standpoint.
Thank you.
And I think that you can look at these diagnostic criteria and maybe recognize that these are really objective findings. There's not really a subjectiveness to them. And I think that's really helpful as you're trying to establish a diagnosis rather than relying on what somebody's symptoms may be. These are really signs and observations that can be made even quantitatively so that you can establish the diagnosis.
Got it. Thank you. The other piece that came to mind was, having children at a young age. How should parents approach their doctors in wanting to know more about the possibility of their child having NF1?
Well, I work in pediatrics, so maybe I see more than Dr. Yohay does, but I think we all in our NF clinics, we're seeing across the whole age group. But I think for families, what we had to convey in a pretty lengthy counseling session is that if a child has emerging cafe au lait spots, it may be 5 to 6 years before another manifestation were to arise. And this primarily is with individuals who are sporadic cases, meaning neither parent is affected. And in the US, about at least 50% of individuals we see in our pediatric practice in the NF clinic are sporadic cases. And so it takes that 5 years is a tough time for couples as they're trying to sort out, is this really going to, what do we need to be looking for and what's in the future? And so to establish an earlier diagnosis, I think sets the stage for families to know what they're dealing with. And I think that's incredibly helpful. And it could be molecular testing. It could be looking for those choroid nodules, which if you can establish that diagnosis, then they know that, they'll want to be followed much more closely, perhaps in an NF clinic. Historically, before we had the more rigorous revised criteria, I would counsel families that we're just going to watch, and you'll come in once a year. We'll make sure ophthalmology will pick up an optic pathway tumor early, but we'll follow you as if your child has NF1, and that's not always very satisfactory for couples. And I would say probably at least half of the families would say, well, if we can do molecular testing to pin this down, whether it's negative or positive, we just want to know and we need to know. It's been very helpful in that regard.
Got it. This question comes just from the perspective of not being in the healthcare arena. How can we explain to parents of patients, of children that have NF, the importance of genetic testing? How does, in layman's terms, how does genetic testing become a critical factor in the diagnostic process?
Well, to be honest, it isn't always a critical factor. We still, even though genetic testing is now part of the criteria, we don't get it on everybody because the clinical criteria are often sufficient. The times that we tend to use genetic testing the most are young children who may have only one feature or just cafe au lait spots and freckling, because that has an overlap with another condition called Leigh syndrome, which is related to neurofibromatosis, but doesn't cause any of the tumor manifestations. And so if you can help a family differentiate between neurofibromatosis type 1 and Leigh syndrome early on, that can be helpful for the family to understand what to expect down the road. So it's important then. It becomes important in situations where there's something unusual about the clinical features or about the clinical presentation of the patient. So there are times when we're not quite sure what somebody has and the clinical criteria aren't quite enough or aren't quite clear enough in that particular person for us to make a definitive diagnosis. So we will get genetic testing at that point. And then the third time that we get it the most is for someone like yourself who's thinking about having a family and wants to know whether or not they can use pre-implantation genetic diagnosis, which can only be done if we know which specific mutation you as a parent has. And so doing testing in someone who's in that process of starting to think about that. We'll also sometimes do that in people who aren't yet thinking about it, but have insurance and, you know, things are aligned. So they're not thinking about having kids right now, but maybe 5 years from now, but they want to have that knowledge up front about whether or not they have an identified mutation. So, you know, the updated criteria, I hope that it makes getting genetic testing easier, but I also hope that it doesn't give the impression that genetic testing is necessary, because it isn't always necessary.
That's the I guess the root of my question is, when should an individual or a parent know that genetic testing is something that should be advocated for?
The way I approach it is really hearing the family and how much will it have an impact in how they approach things with their child and with the medical team. There are times where you'd like to know if an individual might be more severe or less severe. So there are a few genetic changes that can give us some idea of, is someone's tumor burden going to be greater or less than the general NF1 population. So in that regard, it can be very helpful to know if you require increased surveillance, let's say for internal tumors, which, you know, we don't usually go looking for them unless there's pain. And at some point, it seems like everyone has had, as they go through adolescence, there's a time where once you're through puberty, you really want to get a sense of what the internal tumor load is, because that may change how they view things as they transition to an adult. And so to me, it is helpful to, if you feel like you're in the milder category, let's prove it with molecular testing. If you're seeming to have more issues, early onset of cutaneous neurofibromas, more learning disabilities, there may be an increased tumor load. That individual may have a big deletion that not only takes out the NF1 gene, it also takes out 15 other genes on either side, including one that predisposes to a higher tumor load.
Perfect. Thank you so much. Alan, if you don't have any more questions, I think we'll say thank you so much. Excellent. Thank you. I really appreciate everyone being here with us tonight. I hope this video was helpful. I always like to say at the end of these that if you have questions about anything that you've heard tonight, if there were any terms that were used that were unfamiliar, or any concepts that you just want follow-up questions for, please feel free to reach out to me. My information and my contact information is always posted with these videos, so you can reach me at CTF. And I'm happy to talk with patients and families. That is what I do with CTF, and I love it. So I love hearing from the community. If you need anything, please don't hesitate. Thank you again, Alwyn and Dr. Yohay and Dr. Viskochil. Really appreciate you being here with us tonight. And from everyone at CTF, we are grateful for the NF community and for your continued involvement. Thank you so much.